Hello, welcome again, Dr. Anthony Gonzalez with Miami Community Health. We're here to talk to you about another important health topic. And we're going to talk about very important structures that we have throughout our body. Everybody has this. So this applies to the women, it applies to the men, it applies to the kids, it applies to the elderly, the grandmas, the grandpas. We're going to talk about arterial disease, vascular disease. We're going to talk about the blood vessels that we have in our body. And you know that having blood vessels is very important because the blood vessels is what supplies our organs, supplies our arms, our legs, and allows us to work. So what better than to bring a vascular surgeon? You know that I'm preferential. I love surgeons, as a surgeon myself. And so we brought our vascular surgeon extraordinaire, Dr. Tsoukas, with us.
Well, hello, Tony, and thank you for having me. It's a great pleasure to be here.
All right.
Especially at the presence of a great surgeon as
please.
yourself, a great colleague and a friend. So
First, a friend, of course.
We're going to have a lot of fun today.
Yeah. All right. So we're going to talk about vascular surgery today. First, tell us a little bit about a vascular surgeon. What do you do?
So, a vascular surgeon is someone who does interventions. We deal with a little bit more of an acute problem than a vascular medicine or an internist. And the idea is to do an intervention to improve the function or to restore the structure of a blood vessel. And, those interventions can sometimes be very acute. They can deal with life-threatening or limb-threatening problems. And sometimes they're just more elective, and they can serve to restore function, to improve our quality of life.
So in my understanding, there are basically two types of blood vessels in the body. And I think that for our discussion today, let's break them up into the arteries and the veins.
Indeed.
And so tell us a little bit about how the blood vessels work in the body.
So an artery, they're all tubes, right? You have to think in terms of plumbing, but they're very complex and live tubes. They're covered with live cells. So the complexity of the structures is endless. But, for the purpose of simplification, let's think about plumbing. And let's think about plumbing that accommodates circulating fluid. For us, the fluid is blood, but you could think of water in a sense, and the pump. The heart is the pump, and you have tubes carrying water, let's say for the purposes of today, away from the heart into the tissues. Just like you said in your very nice introduction, there's oxygen and nutrition that goes to all of our tissues, including muscles, nerves, brain, intestine, liver, some very, very important structures. And that blood, once it carries, the oxygen and nutrition into the periphery, it needs to return, it needs to come back. And it does come back with a different set of tubes called the veins, back to the heart so it can circulate.
All right. So let's first talk about the arteries. And one of the biggest things that we hear about with arteries, and one of the diseases of the arteries is an aneurysm. So what is an aneurysm? Explain to our viewers an aneurysm.
So just like a true surgeon, you hit the most acute surgical problem there is, right? So mind you, this is not the most frequent. And
okay.
we don't want to scare the audience, because aneurysms can be sometimes acute and dangerous, as we will discuss. But, they're quite rare. If you took, say, 1,000 people walking around, maybe, 5 may have an aneurysm, maybe 1 over 1,000 may have an aneurysm that's significant. So it's not such a frequent problem. But aneurysm is a dilation. It's a sort of like when a vessel blows up like a balloon. When the diameter or the size of the vessel increases to a significant, degree, to a point where the vessel can actually burst. If you think of a balloon that's sort of inflating, eventually you get to the critical point of tension that will burst the balloon. And that's how we get in trouble with aneurysms. Actually, one of the ways, the most frequent way we get in trouble with aneurysms is what we call rupture. So a ruptured aneurysm is probably one of the most acute surgical emergencies there is, right? Because at that point you have a blood vessel bleeding in the body and you have to stop the bleeding. That's a life-threatening problem. You have to save the patient's life and restore the structure of that blood vessel. So these are the things that we sometimes get called for in the middle of the night. We have a limited amount of time of reaction. The hospital needs to be prepared it's really important for the hospital to be organized and to have seen that problem before, or what we call volume of that problem, to be able to have dealt with this problem several times before, to have the volume and the experience to be able to streamline and make an efficient solution of that problem.
So we hope that nobody has to undergo or have that problem of a ruptured
Right.
aneurysm. So how do patients know if they have an aneurysm, or is there a way to diagnose it?
So it's very difficult for a patient to actually know it.
Okay.
Some refer to aneurysms as silent killers because they don't really cause a lot of symptoms unless they rupture. So at the time of rupture, a patient they would know it. They would have a lot of back pain. For example, if it's an abdominal aneurysm, if it's a popliteal aneurysm, there's another set of problems. But they would have a lot of back, abdominal pain. It would be very, very hard for that patient to stay at home. They usually end up in the emergency room not knowing what's going on.
What about the patient that doesn't have a rupture? Their aneurysm that's discovered by their primary doctor or someone like you. How do they diagnose it?
Yeah. So the way and a good primary care doctor would actually know it. I've had the opportunity to see patients in my office sent by the primary care doctors because we call it palpation when the surgeon or the primary care doctor feels the abdomen of the patient. So they put their hands on the abdomen of the patient and they actually feel the pulse of the main blood vessel that brings blood to the lower body, the aorta. So when the aorta, which is probably the most frequent place where you'll see an aneurysm, is dilated, that pulse would be a lot more wide. It would be a lot more prominent. Sometimes it would even be visible. If you look at the abdomen of the patient, you'll see the whole abdomen pulsating. So good clinicians would be able to, just by palpation with their hands, tell that there's something wrong. That vessel feels a little bit bigger. And then they would send them to us, and we would confirm the diagnosis by doing our own, set of exam, but also going to the next step and doing what we call non-invasive testing, where we use ultrasound and the Doppler. We all remember from our high school physics, what Doppler phenomenon is. So we use Doppler, basic Doppler, basically to look at the structure of a blood vessel and look at the blood flow, what direction, how fast. And by assimilating all that information, we can tell if the vessel is looking bigger, is it an aneurysm, how big it is. We can do some measurements, and measurements are important. And from there, we would do more sophisticated testing like a CAT scan, where we would get exact measurements and anatomy delineate, kind of like having a roadmap of what's going on with the circulation.
And does everybody that has an aneurysm has to have treatment for that?
Not necessarily. So
okay.
There are certain sizes that will make the aneurysm more dangerous. At this time, there are guidelines or numbers that are provided by the Society for Vascular Surgery, and that number for men is between 5 and 5.5 centimeters, depending on risk. For women, it's a little bit less because women are expected to have smaller blood vessels, and therefore 5 centimeters is probably the accepted number for women, where we would start looking at treatment. And again, treatment is complex. It's not simple to operate or to do an endovascular repair of an aneurysm. It can have complications. So we look at medical risk as well, the patient's age, the pre-existing conditions, the strength of their heart. Can they take the hit, so to speak, of a big operation, and so forth. So there are many factors that will go into the final decision whether we will proceed with treatment or not.
All right. And so I definitely want to get to some of the toys that you brought for us. I love
sure,
when our
sure.
guests bring toys.
Sure.
And you're going to demonstrate to us how. So if a man has a 5.5, 6 centimeter aneurysm, and he's not ruptured, thank God, and he needs to have repair, explain to our viewers, what it looks like and what is a repair nowadays.
Sure. So and nowadays is very important, and I love historical sort of references, because if you allow me, I'll take you back about 20 years.
Yeah, I was going to say it's changed a lot in 20 years.
Right. When I was doing my training. So as I was doing my training in Boston, what we would do is make a long incision. We would open the abdomen from top to bottom. One of the biggest operations you could do, like an aneurysm repair. And then once we exposed, what would look like kind of like a balloon of the abdominal aorta, this would be the aorta coming from the top, from the head, and just right here, it splits like a pair of pants, one big vessel for each leg. So this would be the aneurysm right here. And, what we would do is expose that whole thing. We would control the aorta right here with a clamp, and these two vessels right here. And once the vessel would be controlled proximally and distally, we would open it and replace this part of the aorta, the dilated aorta, with this graft that I brought you. I had to put a big fight with the operating room to get this graft.
No, we're going to clean it. We're going to put it back.
Well, actually, it's expired. They wouldn't give it to me otherwise. They're very expensive.
Yeah.
So the nurse would open this right in the middle of the operation, and we would take this graft, right, like a tube, and we would sew it instead of this bubble in place, and then we would close the abdomen. It's kind of simple to describe, but it's a very big operation.
That's a big operation. I can tell you, somebody that is a big operation.
Takes a big toll on the patient. And thankfully, there was an Argentinian surgeon, a Cleveland Clinic Argentinian surgeon, who came up with this other solution. Now I'm going to turn my toy the other way and see what we call an endograft. Endografts are like umbrellas that they open from inside. So an endograft is something that we don't need to make this big incision. We can deliver it from the bottom. We make little groin incisions, find the femoral artery, and deliver this. You have to imagine this sort of like a constricted umbrella. Once it gets to this position, it opens up and covers the aneurysm from inside. We call this procedure EVAR, or endovascular repair, and it has by and large replaced this other, older operation. It makes it a lot easier for the patient. The numbers of days in the hospital is significantly decreased. It's not as morbid. The blood loss is significantly decreased. It's a big difference. So we're happy to be becoming less invasive, just like robotic surgery these days. The trend is to create less damage on the way to what we're trying to fix. And this is basically less invasive surgery, what it's all about.
So obviously everybody would want that type of repair. Is that available for everyone, that type of endovascular repair?
So this is our goal. We're trying to have everyone being a candidate, right? But imagine that now you're trying to have this umbrella stick into the normal aorta. These are very important branches called the renal arteries. They feed the left and the right kidney, and you can't cover them. So if there isn't what we call a good aortic neck for this umbrella to sit, it makes it very difficult and very unstable, for this umbrella to actually cover this aneurysm effectively. Now, mind you, technology never stops, right? It never sleeps. So we're always thinking about how we can improve on this. And now we have branched endografts. They are almost ready for prime time. There are certain centers like ours, that will perform, after a lot of planning, will perform branched endografts where we can actually go a little bit higher and have little branches coming into these very important vessels. And I'm sure technology will be there 5 to 10 years from now.
Wow, incredible.
Yeah.
Well, we've learned a little bit about aneurysms. You understand that an aneurysm is a dilatation of that artery. Get yourself a good primary doctor that can diagnose your aneurysm, maybe on exam. Now, one of the things you said is that, aneurysms are not very common. So what is the most common condition that you see as a vascular surgeon in your office?
So if you took 100 patients right out of the street, the most common vascular problem you'd see would be a venous problem.
So that's the other side.
The other side.
Okay, so now we talked about arteries, and we're going to talk about veins.
So the arteries bring the blood to the periphery, veins return it, and the most common vascular problem are venous problems. And one thing I wanted to tell you is that, we are largely responsible for our arterial problems. They, by and large, come because of all our bad habits that we have practiced for decades, for, not just a few years, but for 20, 30, or 40 years. Cigarette smoking, bad eating, not moving, not exercising a lot, and so forth. Venous problems, on the other hand, are largely genetic. We are born with these bad valves that make our veins dilate. Thankfully, venous problems are less morbid, right? They're not life-threatening and they're not limb-threatening. So varicose veins are probably one of the most common problems. Thankfully, we don't die from them. We can live with them. They make our lives a little bit, a little bit more uncomfortable. They make our legs not look not so pretty, but we're not going to lose our legs.
Women don't like it for sure.
That's right.
Women don't like
Right.
it. Okay, so then explain to our viewers how the veins work in our body and all the valves and you mentioned, because we know that the artery is a pump and the heart is pumping the artery and the blood all the way to the toe, right? But how does that blood in the toe get all the way back to the heart?
Right. So that's a great question. I don't know that we actually have answered this question sufficiently well enough, but what we think is going on is that, and again, you have to think of an artery as a high pressure system, just like you described it, and the vein is a low pressure system. So how does a low pressure system actually propulse the blood? Well, it does it by negative pressure. So every time we take a breath, the chest creates like a negative pressure to bring the air in, and that same negative pressure that brings air in also brings blood up. Almost like, pulling the handle of a syringe and pulling, air from one end and blood from the other end. Very efficient. I mean, our bodies are just a marvel.
You got to keep breathing. Breathing is important.
Right. That's right. And breath does so many things for us, So blood comes up because there's negative pressure in the chest. There's no pump that actually propulses venous blood. So every time we stand, gravity, this negative pressure has to fight gravity, because gravity really wants to bring the blood back down to the toe. And you have valves in the way that will close and prevent that blood from coming down. Well, some of us are born, and this, everyone who has varicose veins, they had a relative, a grandmother or their mom or their dad, that they're full of varicose veins. So we know where it came from. And those valves can be, sometimes don't close very well, and gravity wins. Gravity is pulling harder now because you have the entire column of blood that this negative pressure in the chest has to fight, as opposed to just, a segmental column of blood that the valves are creating. So if you don't have the valves working very well, eventually your veins are going to dilate. And, as they dilate, so do their little branches. And what we see with our eyes are the branches of these veins. So you have to think of it as a tree and its branches. We don't look at the root. The valve is the root of the problem. We see all the branches.
So do we go in and fix those valves and replace the valves, or how do we fix varicose veins? You've already told me that it's genetic. You've told me that it's visible, and it's those branches that are now dilated, veins that are dilated. So how do you resolve that problem?
So intuitively, a good vascular surgeon would try to do exactly that. Go in and repair the valve, right? That's you solve the problem. Unfortunately, that's technically very difficult. And every time we've tried it, at least so far, not me, actually, smarter people than me.
Our forefathers.
Researchers and so forth, in some very prestigious institutions, like ours, I should say. They have tried. But the problem with the veins is that the blood is flowing slowly. And therefore, every time to try to fix a valve, so far, blood has clotted. Now, since you mentioned this, one of my younger partners, young surgeons are more optimistic, right? And they get involved in research. God bless them. They get involved in research programs. So my junior partner, Dr. Taubman, has a research program going on right now where we implant a prosthetic valve and try to fix venous insufficiency. We have just enrolled our first patient, and she's telling me, and I have to double check on this, it's maybe the first patient in the United States that we're going to do on this program. And it's something that we're very hopeful, obviously, and we'll have to see how things go. And the next step, because this prosthetic valve is implanted surgically, the next step will be to have something that we can implant with a catheter. But so far, as far as traditional wisdom of vascular surgery is concerned, we can't fix those valves yet. But the veins that have the insufficiency are not irreplaceable. They're usually superficial veins. So we have resorted, for at least the last 100 years, into removing them. If you can't fix it, take it out.
Take it out.
That's what we do. And some of these veins are superficial. They're not absolutely necessary for the body. And traditionally, it's probably the oldest vascular procedure in the book. We would do what we call ligation and stripping of the saphenous vein, right? We would make an incision in the ankle, incision in the groin. We would pull the vein out. Very brutal, if you ask me, procedure. that, had some morbidity, some downtime, pain, bruising, and so forth, but it fixed the problem. Well, that has been replaced too. And
so now we're doing something else.
Technology has had the last word on that as well. And I brought another gadget to show you. This is we have been doing this for about 10 years now. We call it radiofrequency ablation of the saphenous vein, where we use ultrasound to look at the vein, insert the sheath, kind of like we would insert something like this in the tube, and through the sheath we would pass this catheter. This catheter goes inside the vein, and the tip of the catheter has microwave in it, and it hits the vein from inside. So we can, instead of removing the vein and dealing with all the bleeding and the branches and so forth, we close it. We burn it and close it from inside. And the effect is exactly the same. The refluxing vein with the valve is not circulating blood anymore, and the blood can move more efficiently.
Wow. So varicose veins, the most common condition you see a vascular surgeon sees in their office. It's obviously not life-threatening is what I understand, of course. Cosmetically, which could be very also, psychologically threatening for people.
Vexing problem too.
Right, of course. And thank God you don't have to be stripped or ripped anymore. Now you have
hopefully not
microwave your vein. We're going to microwave your vein to destroy the vein. We're destroying the vein, right?
Essentially, that's what we do.
Right,
yes.
and that takes care of the varicose veins.
Yes.
Wow, great. So we've learned a little bit about the artery. We've learned about aneurysm. And we learned about varicose veins. And I want to touch a little bit on a topic of, something that people are scared of, and people, are always mention this word, are scared, and the word of gangrene.
Yes.
Okay. Just today, we were talking before camera. I had a patient in my office who had a spot of gangrene on the heel, and I looked at the patient. I knew immediately that's not for me, and I said, "Hey, you got to go see Dr. Tsoukas." So first, tell the audience what is gangrene and why would I send gangrene to a vascular surgeon?
Right. Yeah. And that's not one of the most pleasant problems to see in your office. But then again, it's a vascular problem. We need to deal with it. So gangrene is whenever tissue dies. Okay, dead tissue is gangrene. And tissue dies when there's no oxygen, there's no blood supply, and no nutrition to it. So anytime the arteries, remember the first category of blood vessels, the high pressure system, is failing to deliver the goods, the oxygen, the nutrition to the tissues, tissue kind of shrivels and dies. And tissue can die in two different ways. It can dry up and die, or it can get infected. If dead tissue gets infected, that's another surgical emergency, kind of like an aneurysm. We call that wet gangrene, and we like the patients to come to the emergency room as soon as possible. It needs to be dealt with because that problem can be life-threatening. But most patients, thankfully, develop what we call dry gangrene. It's sort of the drying, mummified tissue. That's a terrible thing to see, but it's not as dangerous as the infected type of gangrene. And there, we are faced with the problem of how to improve the patient's arterial circulation so that we can remove that dead piece of tissue, and the rest, what we leave behind, will be able to heal.
Right. So the biggest mistake is just to remove that dead tissue.
Well, it's not I shouldn't say a terrible mistake, but okay. It is a mistake because.
But it's not going to work.
Right. If you remove what's dead and you don't fix the blood supply, you left an open wound, and how is that going to heal? You end up with more gangrene, and you have to go further and further. So you need to fix the circulation first. If you have the luxury of time, sometimes patients with the infected type of gangrene, you don't have the luxury of time. You need to get the infection out of the body so that it doesn't spread. But most patients with this dry gangrene, you have the opportunity to improve the circulation. And there are several ways, to do that.
Yeah, no. So that particular patient will need some testing to see what their circulations.
Exactly.
I started with just an examination just to see what their pulses are in their foot.
That's
and
right.
They had no pulses in the foot. So that tells me that there's not good circulation. And so what would you do for this gentleman that has gangrene now?
So on your exam, you can take it step by step. There are different points in the body where you can feel pulses. So you can feel a femoral pulse. Is the problem there, or is it higher than there? You can feel a popliteal behind the knee kind of pulse, and you can feel a distal pulse, just like you said. So you can sort of, with your exam, you can have an idea of more or less where the problem is. But we have obviously more sophisticated tools like duplex ultrasound and non-invasive studying, where we can get exact measurements, and also CAT scan with contrast, or a slightly more invasive study called an angiogram, where we actually get an accurate roadmap of the patient's circulation from a certain point down, at which point we can pinpoint the exact point, the exact area of we call them stenosis, but they're really blockages, the areas where the flow stops. And from there, we can have a plan. Just like any operations officer would look at a map and understand how they're going to approach that area, we look at our imaging studies as a map to know how we will approach the problem and how we'll strategically fix it.
Wow. So we've gone over aneurysm, we've gone over veins, we've talked a little bit about gangrene. And lastly, in the last few minutes that we talked about, we're going to talk, I'd like to go over, stroke and carotid disease.
Sure. Yeah.
And, a lot of people would say, especially our neurologists and our neurosurgeons, and a lot of the audience would say probably your brain is your most important organ. And if you have disease in your carotid arteries, then you can eventually have problems with the brain. So explain to them, a little bit about carotid disease and how that affects your brain and how you can have a stroke.
So I agree with you. I would say I would vote with you that my brain is probably the most important thing that I have. But having said that, there are, in the arterial, the high pressure system, there are very important tubes or arteries or blood vessels that bring blood to the brain. They're called the carotid arteries. We have two of them. And due to our bad habits, such as cigarette smoking, overeating, eating the wrong things, not exercising, and so forth, over a period of years, once we get to our 60s or 70s, we end up with hardening of those arteries or deposition of plaque. They kind of start blocking to the point where the blood flow is reduced or the blood flow can stop altogether. When you have no blood flow, no oxygen going to the brain, for muscle, you can wait probably 6 hours, sometimes 8 hours with really zero oxygen, and you'd probably be okay. With brain, that would come down to about 6 minutes. So these are very time-sensitive problems where the blood flow stops to the brain, and they can be also, sort of emergent. We're very lucky to be, Baptist Health and Baptist Hospital. They have an accredited stroke program, and you can't imagine what hoops we had to jump to name this program accredited, because the state and all kinds of inspectors had to come in and measure response times and so forth. But it is a time-sensitive problem, and you really have to do timely intervention if you're going to improve, the situation and have the patient come back, go back to their lives without a stroke. So anytime, I think that's where you were trying to get to, is anytime we have a stoppage, a decrease of blood flow to the brain, what happens is a stroke. Gangrene of the brain, you could call it.
And that's not recoverable. A lot of that can be permanent damage.
It's permanent. Yes.
Wow. Yeah. So thank God we have the vascular surgeons. They can open up those blockages, and you guys can do a lot of that with catheters sometimes as well, right?
Yes. And, this is not something that the vascular surgeons necessarily do, especially when the clots are inside the brain. We're very lucky to have, we call them neurointerventionalists. They are our partners. And again, we could spend hours talking about MCVI and, Miami Cardiac and Vascular Institute and the place where I work, where we have a multidisciplinary team of experts and specialists in all kinds of different subspecialties of vascular surgery and vascular intervention. So these neurointerventionists now have catheters a lot thinner than this that can follow the bloodstream and go up into the brain and fish clots out and do some very, very amazing things that were inconceivable when I was training 25 years ago.
Wow. The advancement of technology.
Yeah, we're very lucky.
Incredible.
We're very happy to have it.
Well, it's good that we live in a big town like Miami. It's good that we have Baptist Health, Miami Cardiac and Vascular Institute. It's good that we have Dr. Tsoukas and all his partners who help us, whether it be something in the brain or gangrene in the foot.
That's very kind of you.
Something like that. So, we have the care. But, something you repeatedly said, and it's always been a constant theme on this show, is that our lifestyle, eating, exercise, sleep, obesity, all of that impacts disease process. And that's something we hear over and over. And mostly everything you've talked about today is caused because of lifestyle or lack of lifestyle, or people are just not doing the right thing. So I think that's a constant theme that we hear over and over from our guests, our medical professionals, that, eating and sleeping and activity and exercise is very important.
So indeed, and this is one of my favorite topics, right? Because I used to be a fanatic surgeon, where I would want to cut all the time in my early years. But now I'm recognizing that most of these problems, especially the arterial problems, are preventable. And unfortunately, it's not something that you can prevent by decisions that you'll make in, for 6 months or a year. You have to think 10 or 20 years ahead, if you're going to be in prevention. And, but what I tell all of my patients, especially the smokers, that come to my office, I tell them, look around you. We have a very nice office. We have about 20 employees, nice water view and so forth. I tell them, look, without diabetes and cigarette smoking, none of this would exist. Okay. If you eliminated diabetes and cigarette smoking, I would be jobless. I would have to find something else to do. So hopefully, I try to sort of help it sink in that habits are very important, and cigarette smoking is one thing that they can eliminate. It's up to them. I shouldn't say that because, it's extremely addictive and sometimes very hard to give up, but it's something you can change. Diabetes, not so, but again, going back 10 or 15 or 20 years, weight, eating habits, and lifestyle, exercise will affect the rate of adult onset diabetes. I'm not talking about childhood diabetes. That's mostly genetic.
That's different, right?
That's a very hard problem to deal with, but also more rare. What we mostly deal with is the acquired, late life diabetes that, you could say is preventable by the most part.
In most part, yeah. Well, thank you. Another great topic: vascular disease, vascular surgeon.
Thank you. It's been fun.
Oh, it's been great. Thank you for the toys. I love when our guests bring toys for us to see, and for our viewers to see what really happens behind the scenes. Because I imagine there are people that have these things in them, these stents, or have had ablation, and they have no idea what is done. But I want to thank Dr. Tsoukas for being with us. Thank our viewers again for viewing and watching Miami Community Health. And once again, Dr. Anthony Gonzalez, Miami Community Health, signing off. Have a great day.